fucking high. Contrast. Okay. Is fine. Okay. It's fine. Too much time.
Next is Chapter 21 and Central Nervous System Pathology. Now, the first thing we'll talk about are infections. Now, you see here acute meningitis. It can be viral. Of course, we'll talk about how bacteria are very important in causing meningitis as well. Very important is the secondary to viruses, that enteroviruses are typically the most frequent type. And of course, because it is viruses, you're going to see a lot of what? Lymphocytes. Remember, lymphocytes attack viruses, just like neutrophils attack bacteria, eosinophils attack parasites, right? Very good. So these patients are going to have fever, signs of meningeal irritation, and of course, depressed consciousness. Okay? Now, very important, if it's acute purulent meningitis, okay, very important, again, secondary to bacteria. Of course, now you're going to see a lot of neutrophils. Now, remember, very important, if it's meningeal surface grossly as well, okay? Now, very important, you see here, opaque leptomeninges. Again, sometimes I describe it as cloudy in appearance, so be aware of that. Herniations, of course, headache, fever, nuchal rigidity, very important as far as manifestations. Again, cloudy sensoriums, it may alter mental status, not really be with it, can lead to coma and death. Now, like I said, very important, you're going to get this purulent exudate, and typically, if it is bacterial meningitis, the exudate is going to be found on the surface of the cerebral cortex. That's the region of the brain you typically will see the cloudiness. Okay, here's a picture showing you again. This is the brain here, and all this area here showing you cloudy exudate of meningitis in this region of the brain. Okay, so it's very important that typically see it over the cerebral cortex, and we're going to compare that to where you typically see it with tuberculosis. Here it is microscopically showing you Streptococcus. Again, you can see the organisms here. Okay. Here we go again, showing you Neisseria meningiticus, typical diplococci that you typically will see. Okay. Very good. Now, like I said, with Mycobacterium, very important that if you see it, it typically involves the base of the brain. So the exudate will be seen in the base of the brain, as opposed to with bacterial meningitis, again, cerebral cortex. That's very important to remember. Also, don't forget that because of AIDS, that there's an increased incidence of this, particularly caused by Mycobacterium avium intercellulare, which happens to be the most common systemic infection associated with AIDS patients. So that's very important to remember for the STEP exam. Now, very important, now we compare and contrast what we typically see as far as the parameters when we examine the CSF with the different types of meningitis. Okay? Now, typically, very important, if it's purulent meningitis secondary to bacteria, remember, bacteria have a sweet tooth, okay? They love sweets. So, number one, look at the glucose. It's going to be decreased, okay? Again, because it's bacteria, neutrophils will be elevated. So that's very important to remember, okay? Because, again, neutrophils attack bacteria. Protein is increased. Why? Because, remember, you're going to have an exudate. Remember, exudate has increase in protein as opposed to your transudate when we talk about edema fluid. So very important. Low glucose, high protein, again, an increase in neutrophils. Now, you see here the pressure can become markedly elevated. Like I said before, this can lead to herniation. Very important complication associated with these patients. If it's viral, of course, it's mainly going to be lymphocytes. Look at the glucose level, typically going to be normal. Very important complication associated with these patients. If it's viral, of course, it's mainly going to be lymphocytes. Look at the glucose level, typically going to be normal because viruses, they don't like sweets that much. They're trying to watch their weight, whatever, I guess. So the point is, they won't do that. But you will get some increase in the protein, as you see, but only slightly elevated pressure. Okay? Now, moving on to your encephalitis. Very important, we say encephalitis, now we're talking about inflammation of the brain matter, okay? Brain tissue. And typically it's caused by viruses, okay? So very important, you differentiate meningitis from encephalitis. So very important, encephalitis typically caused by viruses, and because of that, you see these so-called perivascular cuffs, microglial nodules. Remember, the microglial cells are the macrophages of the brain, so very important that you get these nodules, and you also get this neuron loss, okay? Now, you see here as far as your clinical manifestations, mental status problems, fever because of the virus infection, okay? Headache, and also may get coma if it does progress. Now, you see here different types of forms of encephalitis. The ones I point out real quick are going to be your herpes simplex virus type 1, typically seen in children, involves the temporal lobes that may become hemorrhagic, and patients may have a history.
Fuck.
Of behavioral problems, acting up in school, or the parents will tell you that they aren't, for some reason they're more aggressive or whatever. So that's going to be the key for herpes. And also you may see the so-called Cowdrey bodies microscopically, small little round eosinophilic inclusion bodies in the cells. Okay? Rabies, of course, the key is going to be somebody either hiking or camping, getting bitten by like a skunk or a bat in a cave or a raccoon or an old possum, that kind of thing. Because they know it can be caused by or transmitted by a dog. So they can give you something else, like I said, either a skunk or a bat or a fox or a possum or that some type of animal like that, giving you that. And you typically see microscopically the so-called Negri bodies seen in the cytoplasm, particularly in the your Purkinje fibers. Okay? And of course, HIV can be associated with encephalopathy, again, altered mental status, the so-called age dementia complex. And the key thing microscopically is you do a biopsy, you're going to see multinucleated giant cells. That's the key. multinucleated giant cells microscopically for HIV. And of course, PML, again, which is related to or associated with HIV, patients also will have the ultrametastasis and that kind of thing too. Okay. Now, as far as your fungal infection, very important that you can see here Candida, Aspergillosis, Cryptococcus, Mucor are your frequent agents. Cryptococcus, probably the most common one, typically seen in AIDS patients, very important. Remember, that's the one for micro you get from pigeon droppings. So somebody works in an office building or likes to feed pigeons in the park. It's going to be a classic presentation for that. For Mucor, you see here, as well as Aspergillus, they like vessels. But classically, remember, Mucor, broad base, and typically seen in diabetics. Classic for the step, right? Broad base, hyphae, and typically associated with diabetes and vasculitis. Like I said, very important, Cryptococcus, seen in AIDS patients. And don't forget that Cryptococcus is encapsulated. And you classically can see the capsule with the India ink preparation. Sometimes you can see it with aramine, rhodamine stain, but India ink is a classic thing that allows you to see the capsule for Cryptococcus. All right, toxo. You can see here, seen in AIDS patients. Don't forget its associations with cat feces. That's why if you have a pregnant female, stay away from the kitty litter. Stay away from the kitty litter, right? So the key with this one is you're going to get abscess, and because of the abscess, you get this so-called ring-enhancing lesion on CT scan. Okay, so that's very important. I'm showing you a picture of it. It's a ring-enhancing lesion on CT scan. Okay, so very important that toxoplasmosis gives you that. Here it is here. So again, the little white area that you see around here, that is the ring-enhancing lesion that's around the central area of necrosis. Now, it's also important to note that our next topic, cerebral abscess, then
This ring-enhancing lesion. This is always
Obviously, also can have a ring enhancing lesion. Okay, now with the cerebral abscess, though, now we're talking about a problem with a patient with infective endocarditis or some other form of way that
Fungal cover. This is a fungal histoplasm. Histoplasm. Protein. This is from. I don't know. In the big space. And butter. So it's just
infection gets to the brain. Staph aureus is classical for causing this. You see here, acute bacterial endocarditis is very important. Cyanide heart disease can be associated with it. Again, gives you a ring enhancing lesion. However, classically, cerebral abscess is found at the junction of the gray and white matter. Okay, so classically, you're going to see cerebral abscess forming at the junction of the gray and white matter, and again has a ring enhancing lesion. And of course, because it's secondary to bacterial infection, they're going to have the fever, leukocytosis, shift to the left, and all those kind of manifestations as well, right? Great. As well as you notice here, they may also have an increase in the cranial pressure if the lesion is significant. All right, now for SSPE, the main thing with this one is patients have measles or so-called rubella viral infection. So now we're talking about a kid, right? Kids get the measles, right? I had the measles way back when. I won't tell you how long ago because you may not believe me. But anyway, so the point is, it's going to be a child. We see it had measles before the age of 2. And then years later, gets the problems with the mental aspect, and then gets seizures and that kind of thing. So very important. They're going to get measles at a very young age, and then years later have the manifestations. That's what you remember for the step. Okay. Now, Creutzfeldt-Jakob disease. Okay, another classical one that they will ask you about on the step exam. So you hear the most common transmissal. Okay, spongiform encephalopathy. Now, very important. It's caused by a prion. A prion is a protein, not a virus. Okay, very important. That's what they can put on the step. That's some type of viral infection. It's a protein, okay, not a viral infection. Okay, classically on the step exam, what they're going to give you is a patient who's either getting a corneal transplant or they're getting pituitary extract, particularly like growth hormone, because a child or whoever is short. Okay, so typically corneal transplant, pituitary extract is the key things in the history for this spongiform encephalopathy. Okay? Now you see here, the key is it causes rapid dementia, okay? As opposed to Alzheimer, it's very slow, occurs over 6 months to a year or so. This will occur within 2 or 3 months, okay, after they've had the transplant or gave them the extract, okay? So very important, rapid dementia. That's the key for Creutzfeldt-Jakob disease, okay? And you see here it goes into all the different aspects of the prion, so the PRP, but again, like I said, just remember, it is transmitted by this prion. Now, like I said, spongy form because of these vascularizations you can see in the gray matter, very important. Okay, now you see here you can get these so-called Kuru plaques, and remember Kuru is a type of Creutzfeldt-Jakob disease associated with eating monkey brains. I guess if you eat raw liver, I guess you eat anything. But the point is that Kuru is associated with that. Of course, you all know about the mad cow disease that we saw in England that was going on years ago. Again, associated with this as well. But again, like I said, very important. Rapid progressive dementia is what you want to see. Notice how you get death within 6 to 12 months. So this happens fast.
Fuck. यार कहाँ गए?
You can see with if very important rate without viral infection. Keep the man or but the point is that Kuru is associated with that. Of course, you all know about the mad cow disease that we saw in England that was going on years ago. Again, associated with this as well. But again, like I said, very important. Rapid progressive dementia.
This is spongy form. Dun, 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 dun. Da-na-na-na-na-na-na.
Is what you want to see. Notice how you get death within 6 to 12 months. So this happens fast. This is quick. It comes on, and the patient just kind of just steadily goes down until finally they die. Okay. This is a picture of Creutzfeldt-Jakob disease. You can see here, these are the vacuoles. Okay. Okay. Very good. Now, like I said, Kuru, as opposed to Creutzfeldt-Jakob disease, associated with eating monkey brains, infected brains, okay, typically seen in New Guinea.
That a brain was that he would bone sponge of mass. Just nice, scrappy. Scrappy, but it is a very Jakob. below. Oh, back up.
All right, so that's what you want to remember. Again, with your CJD, remember its association with corneal transplants and pituitary extracts.
Population gonna go speeds. Na, 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 na. European. Edit attention. Carbonic acid. Which attacks. यार हाँ इसी प्रमेय को इस सैपर oxidic stress all related to hemolysis.
For Parkinson's disease and syndrome, get the enzyme retrieval and disease. Very important. Notice how here, remember, which are one case. Now, that kind of one, but they typically will ask you on specific problems. I'll say with it, loss of motion in or nerve disease. That's a thing. So.
See? So cover.
TT gene froze but the one problem they can have their first patients for you can treat this with pathophysiology the immune system donated plasma basically remove the fascicles. There are sensory deficits, but they're usually sclerosis treatment on your boards because it's extremely complex. It's something done by highly trained neurologists, but just a little bit of this here so you're aware. So rare patients with very mild symptoms and just 1 or 2 lesions and no flares sometimes can be watched without therapy. The mainstay of treatment for patients with mild symptoms is something called interferon. It's injectable and it seems to limit the progression of the disease. And then there are some newer agents which are powerful anti-inflammatories. We don't know exactly how they work, and both of these are sometimes being used. Some of them are oral agents that multiple sclerosis patients can take to try to limit disease progression. Next, let's talk about the Guillain-Barré syndrome. This is an acute inflammatory demyelinating disease, and the key word is acute. This goes on rapidly over days to weeks. In Guillain-Barré syndrome, the Schwann cells get destroyed by the immune system, and recall that the Schwann cells myelinate the peripheral nerves. Patients with Guillain-Barré have an ascending muscle weakness, and remember the word ascending because it usually starts in the legs and then spreads to other areas. This can be serious and life-threatening. About a third of patients can have respiratory failure where they end up on the ventilator from Guillain-Barré. More than half of patients end up with facial muscle weakness, so they have drooling and dysphagia. There are some sensory deficits, but they're usually very mild, limited to things like paresthesias, which are just numbness and tingling in the extremities. And the symptoms usually resolve over weeks to months, but it can be a brutal few weeks to months. If you ever see a patient with Guillain-Barré, they can be extremely debilitated until the condition resolves. So this is a picture of a peripheral nerve, and we talk about this in another module on basics of the nervous system, but you should know that the endoneurium right here is the classic area that gets affected by Guillain-Barré. So when you hold a nerve in your hand in the anatomy lab or in the OR, what you're holding is a nerve trunk, and that's this whole structure here. But inside of it, it has all these fascicles surrounded by a structure called the perineurium. Inside the fascicle,
Just making this fucking irritating part. Fuck. Na 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 Okay, meet you soon. It is time for break. Na, 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 na. La, la.
Hello everyone and welcome to our module on gaze palsies. Conjugate gaze refers to movement of both eyes at the same time in the same direction. You need your conjugate gaze in order to look right or left with both eyes for things like tracking objects. And when a patient develops a conjugate gaze palsy, this means that the eyes cannot move together in the same direction, and this results in diplopia when looking in one direction or another. In order to understand conjugate gaze palsies, we need to review the neural circuitry that's involved in looking to the right or left with both eyes. So in order to do this, let's imagine that we have a right eye and a left eye, and let's imagine that we want to look to the right. In other words, we want to look in this direction. This process will begin in a structure in the brainstem called the PPRF, which is the paramedian pontine reticular formation. This structure will send signals to the nucleus of cranial nerve 6, the abducens nucleus. That nerve innervates the lateral rectus of the right eye, so it will move the right eye to the right, which is what we want to do. However, we also need to activate the medial rectus of the left eye. In order to do this, there are nerve fibers from the cranial nerve 6 nucleus which can activate cranial nerve 3 for the opposite eye, and then cranial nerve 3 will activate the medial rectus. The nerve fibers that carry those signals to cranial nerve 3 of the opposite eye are called the medial longitudinal fasciculus, and this is a very important neural pathway for conjugate gaze. Here's a slide from our brainstem module showing you the anatomy of the pons. I just want to point out to you that cranial nerve 6 is located here and travels in this direction. It is surrounded by cranial nerve 7. Just inside of the nucleus of cranial nerve 6 you can find the medial longitudinal fasciculus fibers, and right next to those you can find the paramedian pontine reticular formation. So just to summarize the key points about conjugate gaze, the PPRF initiates lateral gaze from the brainstem. It's located in the pons. The medial longitudinal fasciculus carries signals from the PPRF to cranial nerve 3 on the opposite side, and conjugate gaze requires functioning cranial nerve 3 and cranial nerve 6. Now that we understand that circuitry, let's talk about our first conjugate gaze palsy, and that is an internuclear ophthalmoplegia. This is a horizontal gaze disorder. It's a problem with the eyes looking to the left or right. It involves weak adduction, which is medial movement of one eye, and the affected eye cannot move towards the nose because of weak adduction. The unaffected eye develops nystagmus, which we'll talk about in a minute, and this problem is caused by lesions of the medial longitudinal fasciculus. When you have a lesion of the MLF, the clinical syndrome you develop is called an internuclear ophthalmoplegia. Importantly, convergence is usually spared, so patients who have an internuclear ophthalmoplegia can't look left, they can't look right, but if they try to look to the middle with both eyes, which is convergence, that is usually normal. That's because it has a different neural pathway, and cranial nerve 3, which innervates the medial rectus muscles for both eyes, is working properly, and therefore convergence is okay. To make this more clear, let's consider the example of a patient who has a left internuclear ophthalmoplegia. This patient will have eyes that are midline at rest, and when the patient tries to gaze to the left, everything will be okay. In other words, if they try to look left, the right eye will move left and the left eye will move left, and everything will appear normal. However, when this patient attempts to gaze to the right, there will be a problem. The right eye will move to the right as it should, but the left eye will not move medially past the midline. That's because there is a problem with the left medial longitudinal fasciculus, and thus we say this patient has a left internuclear ophthalmoplegia. Past the midline, that's because there is a problem with the left medial longitudinal fasciculus, and thus we say this patient has a left internuclear ophthalmoplegia. If we go back to this slide, a patient with a left INO has a problem with the MLF fibers that innervate cranial nerve 3 from the right side to the left side of the body. When this patient attempts to gaze to the right, the lateral rectus muscle will be activated as it should, and therefore the right eye will move laterally. However, there's a problem with the MLF innervating cranial nerve 3 on the left. Thus, cranial nerve 3 will not receive its normal signal, and it will not activate the medial rectus muscle. This means the left eye will get hung up and will not move medially past the midline. And I've summarized these points at the bottom of the slide. You need your MLF to move the eye medially when the other eye goes lateral. The side that cannot go medial is the side with the MLF lesion, and when there is a problem looking to the right, this means there is a left MLF lesion. Just to make this point even more clear, I've shown a series of eyeballs on the screen to help you understand a left and right INO. So a normal patient has eyes that are midline at rest, and the patient can gaze right normally and can gaze left normally. A patient with a left INO will have eyes that are midline at rest. When they attempt to gaze to the left, that is normal. However, when they attempt to gaze to the right, one of the eyes is hung up and cannot move medially past the midline. A patient with a right INO has the opposite findings. The eyes are midline at rest. When they gaze to the right, that is normal, but when they gaze to the left, one of the eyes cannot move medially past the midline. An internuclear ophthalmoplegia occurs because of damage to the MLF. This is sometimes referred to as an MLF syndrome. This involves lost MLF input to the oculomotor nucleus on lateral gaze. The adducting eye, the eye attempting to move medially, will be unable to do so past the midline. You should also be aware that the other eye, the abducting eye, will develop monocular horizontal nystagmus. Nystagmus is repetitive eye movements, and this occurs because the eye moves smoothly laterally, but then the brain recognizes that the eyes are out of alignment, so there is a rapid movement back to the midline. This is called a saccade, and this leads to the development of rapid eye movements, which are called nystagmus. So if you look at the bottom of the screen, what happens on lateral gaze in a patient with an MLF syndrome is that the adducting eye has no movement past midline, as we saw on the last slide. The abducting eye develops nystagmus and saccades, and that's because it moves laterally, gets out of alignment, and then is jerked back towards the midline by the brain. The most important cause of an MLF syndrome for you to be aware of for step 1 of the boards is multiple sclerosis. The MLF is highly myelinated, and thus when demyelination occurs in multiple sclerosis, an MLF syndrome can develop. Another neurologic problem that can sometimes be confused with an MLF syndrome is an abducens or cranial nerve 6 nerve palsy. This problem also produces a gaze disorder, but it has different features from an internuclear ophthalmoplegia. If we go back to this slide, when you gaze in this direction, you need cranial nerve 6 to innervate the lateral rectus muscle and move the right eye laterally. So if there is a palsy of cranial nerve 6, one of the eyes will have difficulty moving in the lateral direction. To understand this better, I've once again shown a series of eyeballs on the screen. So at the top is a normal patient with eyes that are midline at rest and eyes that gaze to the right and also gaze to the left normally. In a left abducens nerve palsy, the left eye may be pulled medially because the lateral rectus muscle is not functioning normally. It depends on the severity of the lesion, but whether the eye is medial or not, the problem will get worse on horizontal gaze. When
Wait.
patient gazes to the right, that will be okay. But when the patient attempts to gaze to the left eye will not be able to move laterally. That's because of the cranial nerve 6 nerve palsy. In a right abducens nerve palsy, the findings will be the opposite. So the key points I've summarized at the bottom of the screen. You want to look at the eye that is stuck. Is it trying to move medially or laterally? If it's trying to move medially but cannot, then that patient has an internuclear ophthalmoplegia. If it's trying to move laterally but cannot, then that patient has a cranial nerve 6 palsy. Let's talk about some other lesions of the conjugate gaze system. Let's talk about what happens if there is a lesion involving the PPRF. This will lead to an ipsilateral gaze palsy. In other words, there will be paralysis of conjugate gaze to the side of the lesion. The patient will not be able to look toward the side of the lesion. That's because the left PPRF coordinates leftward gaze. There will be preservation of convergence because that's a different neural pathway. And this can happen when there's if you've got a lesion involving the medial pons that can damage the PPRF. If we go back to this slide, if there's a lesion that takes out the PPRF, you basically won't be able to initiate gaze toward that side of the body, and therefore you will have a conjugate gaze disorder when trying to look toward the side of the lesion. We talked before about what happens if there's a nerve palsy involving the abducens nerve or cranial nerve 6, but what happens if there's a lesion in the brainstem involving the nucleus of cranial nerve 6? Well, this will lead to findings that are the same as a PPRF lesion. There will be loss of lateral gaze on the side of the lesion. That's because the PPRF activates the nucleus of cranial nerve 6, which in turn initiates lateral gaze towards that side of the body. Back to this slide once again, the PPRF activates the nucleus of cranial nerve 6. If there's a lesion that takes out this nucleus, then that will be the same as having a lesion to the PPRF. You will not be able to initiate lateral gaze towards this side of the body. The 1.5 syndrome is a gaze palsy that can occur when there is damage to both the PPRF and the MLF, and this can happen because these structures are located close to one another in the brainstem. Patients with the 1.5 syndrome develop an internuclear ophthalmoplegia plus loss of lateral gaze to the affected side. To understand this, let's look at the bottom of the screen where I've shown what can happen with a left 1.5 syndrome. When a patient with a left 1.5 syndrome looks to the right, they will develop symptoms of an internuclear ophthalmoplegia. That's because there has been damage to the left MLF. Thus, when they gaze to the right, the left eyeball does not move medially past the...
That's it.